So this is the Cath lab extraordinaires. Sherwin, you want to do the introduction of your...
Well, I'm Sherwin Lott. I know a few of you seen you around. I worked with Lindsay for a lot of years. I manage the Cath lab and the electrophysiology lab and our recovery unit. This is Tim Glover. He's our coordinator over there, an educator, so he's the one that helps keep everybody up on their skills. He's been in the Cath lab for how many years now?
It's about 12 total.
I've been at Intermountain, it'll be 25 years this next month, and or in October, and that's all I've done as far as I don't know a whole lot more. This is Shay Hardy. He works in our Cath lab as well, and he started my CRU unit. And how long have you been over there? You worked in the ICU before that?
Yeah, about 7 years.
So when you look at most of the teams, when you come in with our 4-man team, you usually have at least 50 plus, sometimes closer to 100 years of experience with the 4 guys that are in there, so, or girls. So we have a few girls still in there, so we like them. But, we're gonna do some little hands-on stuff here as well, show you kind of the tools that we use, because the cool thing about cardiology is there's always something new, and there's a ton of toys we get to play with, which is awesome. And I'll let Tim start with this, and then we'll go from there. He created this little thing this last week, because man.
All right, Tim.
And Dean, he sits on our ischemic heart team, so does Renee. And I'll tell you what, over the years, with you guys' help, working as a team, I mean, our door to balloon times were, a couple hours a lot of times, stuff like that, and we are down to, our average for this year was 49 minutes.
They do amazing times.
So that's unbelievable. I mean, so all these EKGs in the field you guys are getting for us, just all the process improvements. I mean, Dean sits on the team, Lindsay used to sit on the team. Every time we think we can't make any more changes to decrease time, like it's almost monthly, somebody comes up with something, we're able to push it just a minute or two off. So,
and I've got two loose leads full of 12 leads. And the other good thing is they're sending us the results when we bring them in. They encourage you to go up and follow it through. And then they'll send us the before and after pictures of it being cleaned out, which is really cool as well. But I got 2 loose leads back there full of 12 leads. If any of you want to go through 12 leads, we can do that as well. Firehouse training, it's EMO4, is what we're doing. So anatomy, physiology of the heart, and just make sure you add that into your notes. And of course, just a reminder that our 48-month training program is on the T drive. So if you're wondering what you're supposed to be studying this month, go to the T drive and look. It's not only EMS, but there's all the fire stuff as well, so be utilizing that as well. Reminder for those that are due national, it's due next month, so make sure you're getting your hours in. And for those that are recertifying in June for the state, if you have any questions on the application, I'll let Jonathan talk to me today, but we can help you out with that as well. All right, now really.
Okay. Appreciate you guys letting us come out here and talk with you. As you all get called out. Great. Oh, I see how it is. Okay. Yeah. Oh, I think we got a STEMI too. We got to go. So some of the things that we were asked to talk about in this presentation today were the hospital expansion update. There's, with you guys have had to deal with the construction just as much as we have had to deal with it. It looks like a big mess, but it's coming together. So I don't know if we can dim the lights down a little bit, or if you guys can see that okay. We like to see this is the artist rendering of what we're going to look like. So currently here's our west building, and the ER was back here. Eventually this east tower is going to get torn down. We're going to have a nice pond here. They call it the healing garden. This is the outpatient center, so it's going to be a lot of the doctor's offices and different things like that. This is the big patient tower. And give you an idea, this is what they have a rendering of what it's going to look like at night. So the south entrance is over here, ER entrance, where you'll be able to have ambulance parking and whatnot will be around on the corner. Another picture of what they expect the healing garden pond to look like. Nice area for patients and families and staff to just kind of go back and relax. So again, another view of the entrance where patients and families will actually have a roundabout here where they can drop patients and family off, and it'll be a nice little covered.
Tim, is Sherwin advocating for fish?
Oh, for the fish pond, hey.
We told them we were gonna fly fish.
Yeah.
In between.
That would be awesome. But I think amongst the Cath lab, we'd get rid of all the fish too quick. We'd have to keep it stocked. Here's an aerial view so you can understand. This is that big patient tower. The roundabout for the patient main entrance. And then here's the emergency department here, where we're going to have ambulance parking and emergency room entrance for you guys. This just gives a graphic of what's actually going to exist on those floors. The main floor, you can't see too much there, but that's going to be the cafeteria, the ER, the main lobby. And we're going to have second floor our Cath lab. That's what we're really excited for, right above the emergency room. On that second floor, it's also going to be all of surgery. So that's kind of a new change that we're going to be experiencing.
Yeah, it's going to be 100,000 square feet of interventional floor. So basically GI, radiology, surgery,
and it's
Cath lab, everything all on one floor.
And electric and the physio.
We'll have our 4 labs will be right together. The first lab where we'll do stemmings is right out of the elevator. So when you guys come in, boom, it's right out of the elevator from the ED straight into our lab.
So where we're talking about improving our times, this is going to be huge. I just wanted to show what patient rooms will look like. So if you guys get the opportunity, which I know you do all the time, take patients directly to rooms, you're going to actually have room to take these patients in there, and it's going to be really nice. We've increased the size of the patient rooms to all be standardized. I believe it's 300 and something square feet. I've got the stats here, but every patient room will have a view. They're all going to be on the outside of that patient tower, where all the nurses' stations and all of their things are going to be in the middle, off site, out of the way from everybody. So it'll be nice for patients and families to actually not feel trapped in their rooms. This is a floor plan of the ED. You can see it's pretty massive. It's pretty big. One of the things that I like to point out is we've got our EMS break room, which is it's always nice for you guys. We've got one of the most big changes and great changes that we have is we're gonna have 24 observation beds. So in the past, where we had patients coming in the ER that don't necessarily need to be admitted into the hospital, but we don't want them in the ER tying up space and beds. Now we have the option they can go to a 24-bed observation unit, which is huge. It's awesome. We've got the second floor plans here. So as Sherwin was saying, we've got our pre-op recovery, our PACU, our OR, the GI lab, more OR support, specialist lab, a hybrid lab, and then here's where we will be. We have Cath lab, EP lab, EP lab. And as Sherman said, the elevators are right there by our Cath lab. We're really excited for that. So kind of blow that up just so you can see those elevators go directly right down to the ER.
And since this area is going to be a red line area, it's like going into a OR. We put it there because we know that we're not going to try to slow you guys down and make you gown up and everything. Since that lab is right there, Cath lab, as long as we don't have a bunch of stuff open, whatever, it's covered, you guys are able to come in and out quick. So that was something we've already worked through. So when you come up there, we're not going to have you gown and everything. You're just going to get the patient in, and you guys can stay back in the control room and watch as you usually do. But once you're in there, you can't really you're not really free to roam about that floor too much once once you're in there, so.
And as you
Without
see,
being-
it'll be a maze. You'll get lost in there. There's going to be a lot of closed doors that badge access only will let you get through. So it's awesome that they've designed it so we get that quick access from you guys. So just a timeline for you to see. We're doing that new patient tower construction. You can see it's going to go through 2018. The hope is it's finished in September of 2018 and occupied by October of 2018. They've already done the new grounds for the Lifelike construction. They had to move that over. They're building that new outpatient building, so it's the other big building that you've seen going up, and they're actually expecting this year that they're going to have that occupied.
That's the one by the current ER, right?
Yes, it is. And so, as I'll go back here, that was going to be, well, maybe I didn't pull up that one. It's going to have our cardiac rehab. It's going to have other physician clinics. Our outpatient cardiology building will exist in that new area. Then they're going to have to start constructing a new south entry drop-off. As you see already today, they're starting to actually get rid of where we had the fountains. They're getting rid of the two-tier parking that was there, what we call our Northwest Plaza. And that's for more future parking that will go there.
When does the Northwest Plaza go?
It's coming soon.
We're starting to move people right
yeah.
now, so.
So they moved out a huge group of our
All the
billing
and
people.
everything's now in
I saw him do
East
some
Bay.
touch-up painting there, and I said,
yeah, why? Exactly, because it's coming down, so
I think it'll be within about 6 months.
yeah. So it's coming along pretty good. So just some key points about the hospital replacement project. One of the big things about our East Tower, it's old and it does not meet code. So the hospital met with specialists to see what it would take to bring it up to code, and it would cost more than this replacement project would cost. So it actually is more feasible for us to build these new towers than to try to reinforce our existing tower. We want to consolidate services. One thing that's really nice is that, for instance, our cardiovascular service line, right now we have the cardiovascular ICU on the 2nd floor. We have our telemetry floor up on the 5th floor of the East Tower. You know, it can take
Outpatient cardiology.
outpatient cardiology way over.
We're in 3 different buildings for
Yeah.
Cath and EP.
Yeah, so it's really nice to actually get things all together. So we'll have, all of ICU is going to be on the 4th floor. All of cardiac is going to be on the 5th floor. And so that's gonna help create relationships between the departments, keeping us closer to those who we work with. They wanted to. We all want to be green. That seems to be that's the key word these days. Is we want to be green. So as you saw, we're going to have that pond, that healing garden area for some green space. We want to utilize on-stage, off-stage, and what that means is they want to have the nurses' stations and the supplies out of the way, and they want to make more of a clean look for the patients in hopes that it's less chaotic and better for them for their healing. They've designed the rooms so that nurses can actually stock the rooms with supplies from the outside of the room, so they don't have to go in and bother the patient, allow them to rest. And so we're going to have larger rooms. So there we go. Right now we have an average size of 225 square feet for our average room size. Going to move it up to 300 square feet for every room. The new observation unit in the ED, 24 beds as I mentioned. So decentralizing the nursing stations. So the nurses now will have nursing pods where they'll actually be right by their patient rooms instead of down the hallway into their own nurses station, which so you'll hear the nurses complain about it, but we hear from other facilities that do it, it's made a big difference in treating their patients. Utah County is growing, and you guys know that. We've got so many people that realize it's an awesome place to live. So in 2010, there was about 500,000 residents that lived here, and we're projected to have 1.2 million by 2050. That's crazy when you think about that. That's just going to make you guys busy and us a whole lot busier too.
So why did they do a hospital replacement instead of a bigger
A
hospital?
brand new hospital.
Yeah.
Well, so I don't have all the answers for that. A lot of it has to do with this is the space that we own. This is what we have. To find new ground, it would be really a big challenge. When IMED changed and built their big facility, that was a big headache to take all their hospitals and try to move into that one when they finally did get it. They just found that this was going to be what suited us best.
And if we wouldn't have been able to acquire the land around it, that's what we would have had to do, what we would have had to have done.
So you guys probably remember all those
It took like
homes that we
10 years
took down.
of working to get that. I mean, it was a 10-year process to get that all purchased.
But that's a great question. One of the nice things about this construction is we've got shelved space. So we're going to have the potential to add 36 more inpatient rooms in the future. So we do expect that we will need to grow. Hospitals always have to grow. And oftentimes it's either you grow up or grow out. And since we don't have the footprint, we had to go up.
And right now, we don't have a big addition with this new building of total beds. We really don't. Healthcare, as you know, hospitals are only places that people that are really, really sick should be. And so with all of the outreach and everything else we have, we don't expect to see more beds full, really.
I was just gonna comment that, they're still working on the Spanish work
Yes.
Yes.
hospital
the Spanish
as well,
work
so
hospital
that
will
was
be going
part of
in.
this.
They'll be breaking ground in 18 on that, I think. That'll be more of a
Community.
surgical baby hospital, kind of like one.
Yeah, so total beds 383. I think currently we really don't go up that much. I think we had 376, something like that. So it's not like we've got more beds. The one thing that we do have that we didn't have before will be the 24-bed observation unit. So next we want to kind of transition. Well, actually, before I go on, any other questions about the hospital expansion project? I'm not an expert, but I'll tell you what I know.
The 24-bed observatories, what's that going to be covered? There can be doctors there, nurses,
Yeah,
clinicians.
We'll have
Yeah.
full-time doctors that are in there that basically is somebody that, before we admit them to the hospital, if they're only gonna be there for a day, even 23 hours, we'll run everything while they're in there. So if they think they need a treadmill, they'll just go have the treadmill done, do all the workup, and then never enter the hospital. So, and it'll be doctors will be right there all time, 24 hours a day. So instead of waiting for those tests and everything that we do, I mean, they run all the tests, they get everything done, and the people just stay there. And then if their diagnosis is, well, yeah, they've got cancer, yeah, they need a heart cath, then we'll admit them at that point. But that'll keep the hospital from being clogged up so much.
And it helps patients reduce their costs of their hospital
Yeah.
stay. It's huge in that way. Yeah, Renee?
Before you get into that, Devin was just mentioning that he talked to the ER doctors and that there's a gear up process for this. And they'll have, in fact, I've already been invited to meetings with, key people to plan this transition into a bigger kind of thing. So we're trying to hire more nurses now.
Oh, yeah.
We're trying to hire more doctors now. We have quite a few doctors coming to the ER this summer,
Thanks.
so.
Thanks.
For us, what's going to be really different for us is that right now when we deliver patients, we are competing for the same doors in a lot of cases as the public walking in. It's on totally different sides of the hospital now. So walk-ins now come in off of the west side, and we're going to be coming in from the east side, and it's gated, and there'll be a card assigned to each rescue, so you'll actually, a lot more secure for us to come in through the gate shuts, you unload your patient, gives you a place to park right there, and when you leave, it's also gated to go out as well, so that'll be really different for
Yeah.
us.
Yeah, I'm really glad that they planned that and got that set up. Hopefully you guys enjoy that. Any other questions or thoughts about that hospital expansion? Okay, so now to things that I actually know really about. Let's go into heart disease. So as Sherwin said, I've been in the cath lab for about 12 years. And so hearts, that's all I know. One of the things about cardiac that got me excited is that I knew that I'd always have a job taking care of people's hearts, because heart disease isn't going away. It's the #1 killer of Americans. They're showing this statistic: 1 in 3 adults suffer from cardiovascular disease. That's 92 million people here in the U.S. that have heart disease. And it kills 2,200 people every day. So that's a death every 40 seconds. So we're always proud about the people that we're able to save, but there's so many more people that don't even ever make it to the hospital that die of cardiovascular disease. It is also the most costly killer. So the amount of money that it takes to treat heart disease and then after the fact, it's mind-blowing numbers how much money heart disease actually ends up costing. So by 2035, it's projected that 45% of the U.S. population will have some form of cardiovascular disease. One of the interesting things is the amount of deaths that we have from heart disease and the amount of the National Institute of Health funding for heart disease. Heart disease isn't sexy. We're not breast cancer. We're not these other movements that really get the big backing. Bill Gates, he doesn't put money into heart disease. He's looking at cancer. He's looking at those kind of things. But here we are. We're the #1 killer, and we want to get more funding so that we can actually get rid of heart disease. We're good at treating it. We're not good at getting rid of it. So you see, the $1.1 trillion is the projected cost of cardiovascular disease by 2035. That's just an insane amount of money. So it's a huge burden on our healthcare system. It's a huge burden on the taxes on everything. So we're all helping pay for that with all of our taxes. So we're going to go into what we do in the Cath lab. How many of you guys have the opportunity to actually come in and actually see the procedures when we actually do it? So that's what we want. We want every single one of you to have that opportunity. I know there's times you bring us a patient, you got to run to the next call, but you guys are part of our team, and we want you to feel that way. We're not successful without you guys. So I should have put you guys first on the Cath lab team, but in the Cath lab team we have registered nurses, cardiologists, rad techs, respiratory therapists, in some instances registered cardiovascular invasive specialists. There was a school where high school grads could get their training and certification, kind of like a scrub tech, and they work in Cath labs. We currently have licensed professionals in our Cath lab with nurses, rad techs, and respiratory therapists. So when you come in, we could be any of those professions. But in the Cath lab, we are all treated the same. We all come in, and our job coding actually gets changed to become cardiovascular specialists. So that way, we don't have nurses thinking that they're better than somebody else, and vice versa. We all just work as a team. We're all in it together.
We can do every job
And
in there. So our respiratory therapists can do meds just as well as the nurse, and they just switch around. It makes it so we're a lot better team. When I was first in the lab, we didn't have that, and so as Lindsay can remember, sometimes you'd be the only nurse in there, and things would start to circle the drain, and you'd look around for help, and you really were the only one that could help, because the rest of them had no idea what your job was. And so now that's gone. If I need help, I can look at anybody in the room, and they can help me.
So you guys can attest it's similar to your jobs. It's really nice to not be the only one doing a job. You have backup. You have those around you that can help support you. So there are different roles when we're actually doing procedure. Obviously, the cardiologist, the doctor, he's the primary operator. One of us gets to scrub in with him. We'll assist with the procedure. There's a circulator, this person giving the meds, opening equipment, and the recorder, the dreaded job that we all have to take turns on doing, but somebody's got to do the charting of the
The
procedure.
cool part about being the scrub and stuff, and And being in there, everybody thinks the doctor's doing everything, as Lindsay can attest. We're the ones that inflate the balloons, we're the ones that pin the wires, we're the ones that inject the arteries, we do all that stuff, and then the doctor bills and gets a lot of money. So we do a lot of, the work. It's hands-on, you're not just standing there, and you're actually the one that's doing,
So really the doctor is
The doctor-
conductor of the chaos.
He does the
There you
conductor,
go.
he is the conductor, he actually gets the wire where it needs to be in the balloon, and then you pin the wire and you inflate the balloons. I mean, he calls those shots, but you're the ones that's actually doing that stuff. You're injecting the arteries, and he's moving the x-ray so that you get the right pictures, but you're highly involved in this, and so it takes some good training and a lot of trust between the doc and the staff.
Who are some of the docs? Cragen and...
Right now, our interventionalists, we only have Dr. Cragen, Dr. Weaver, and Dr. Bingham, and he's now the president of Revere, so I mean, we call him a half cardiologist. We got 2.5 interventionalists right now, and we really need like 5 or 6.
Yeah,
We're,
we have a big need. We're trying.
we need more cardiologists, big time.
Yeah.
So,
Yeah. So, in the cath lab, we can do different procedures, but the primary procedures that we do are cardiac diagnostic and interventional procedures. So those are the angiograms. We take a look at the heart. Interventional, that's where we're putting the stents in, opening up arteries. We also can do peripheral diagnostic and interventional procedures. So we have some patients that come in, they have pain when they walk, and they actually have clogged arteries in their legs. We're able to fix those. We're also able to do what we call IVC filters. We put them in the inferior vena cava, and it helps to catch clot so it doesn't go up to their lung and cause PE. We also do heart rhythm device implants and removals, so we do pacemakers, we do ICDs, and Shay's got just kind of a little model here. He's got a so some kind of cool stuff. So we're using X-ray in there, using some radio contrast agents, so we can actually inject that into the blood, so that we can actually see what the arteries look like. We can also do an IVUS, which is taking an ultrasound catheter into the artery itself and doing an ultrasound inside the artery, and lots of other tools that we can use to visualize and see what's going on with the heart. So I'll show you just, this is the cath lab that I wish that we worked in. Look how clean it is.
Right off of Google, like
How
images.
Absolutely, yeah.
our new ones are going to be.
Our new one, yeah, new one, we're going to be finally a nice new lab. In the Intermountain system, we've got the oldest cath lab in the system. And, a couple months ago, we had some folks down from Dixie come up and shadow with us, and one of the gals was like, you got an awesome team, but man, how come you're working in such an old lab?
Yeah. So we're replacing actually 3 of our 4 labs with all new equipment, along with new buildings.
Yeah. But you guys have been in there. It kind of looks like a lot of chaos in there. We've got, it looks like a storage room. But we've got a lot of cool tools that we can use in the cath lab. But this is the fluoroscopy unit. That's how we take our pictures, and it is able to move into different angles to get different angles of the anatomy of the heart. Because we're trying to look at a 3-dimensional object, getting a 2-dimensional view, so we need to rotate around so that we can find the
I saw
arteries.
someone that signed that wall there in your lab. It said Frankenstein or something.
Frankenstein's
Yeah.
lab. Well, yeah.
That old.
Yeah.
Yeah. So there's different methods to actually get access. So we can either go through the groin. The femoral access, we can go right or left side. Once we get into the artery, all roads lead to the heart. So we can go right or left side depending on the need of the patient. So you'll see when you get up here, we have tools here. We have sheaths. Sheaths, I always say, are just kind of like a big IV that we insert into the artery, allow us to get our equipment in without having blood spilling out the whole time. We can also, in order to actually get access, Doc's going to feel the pulsation of the artery, take a needle at about a 45-degree angle, and slowly insert until he gets blood return coming out. He's going to take a wire and insert that through that needle, remove the needle, then he can take the actual sheath in, which has a dilator on it. It makes it a little stiffer so that it can actually go over that wire, and then we have our access. Right now, the popular thing to do is actually to go in through the radial artery. A lot of reasons for this, because now we reduce bleeding risk going through the radial artery. It makes the patient's life a lot easier for recovery, because now they're not going to be stuck on bed rest for hours after the procedure. In fact, they could get up immediately after the procedure. They could get off the table. However, we sedate them, so it wouldn't be a good idea to have them get up and walk around. But our patients are loving this way. We're having patients more and more actually requesting that their doctor do a radial technique instead of going through the groin. Particularly,
more doctors do it.
Yeah, I'd say we're probably about 85% of the time now doing radial, and
The
the
nice thing is,
docs want to do it.
just those radials, the nice thing when they're done, it's just this band we put on their wrist. It's just got this balloon pocket inside of it. So this just fills with air, kind of holds pressure against that artery. You can kind of just see that air pocket there. And then within 2 hours, it's off and they're good, whereas
The old days, we'd have to hold pressure for half hour, then we would have them on their back with a sandbag for hours and hours and hours.
Yeah, you got some of the old school patients that they remember they call it the vice. There was it was brutal. It sounds just exactly like a vice that was placed on the puncture site and clamped them right to the bed.
when we go through the femoral approach, this is kind of the closure device. It's a little foot that goes inside the artery. Then this collagen, as soon as it hits the blood, it starts to expand and kind of fills that hole. So we put this in the artery, seal it, and kind of that seals that hole. But the patient still has to lay flat, without bending that leg for 4 to 6 hours, and it can still fail, and they can start to bleed internally sometimes. So those radial ones are kind of nice.
So just kind of showing, you can go right arm, left arm. Like I say, once you get into an artery, it's just going to lead to the heart. So this is just kind of a still shot of a normal looking left coronary artery. We've got the LAD with its branches called the diagonal branches. We've got the circumflex with its branches called the obtuse marginals. It took me years to know what I was looking at when we were doing these at the beginning. Just another view of what a normal looking left looks like. Again, LAD, it's feeding the anterior front part of the heart. Circumflex, feeding the lateral part. And here's the right coronary artery, feeding the inferior part of the heart. So some of you have come in, maybe you've actually had the opportunity to see instances like this. This is an LAD that's completely occluded. So it came in, STEMI, writhing in chest pain. You see exactly why there's clot right there. It's completely blocked off blood flow. And we're able to balloon, stent that open, and look at the arteries there, what was missing. That's a whole lot of blood that's not getting to that heart muscle.
And then, as you can see, you've got the catheters that are coming in there to inject.
Yeah, they're there.
These are the different types of catheters. So this is the one that we use to go into the left coronary system. This is the one that we use to go into the right coronary. They have different shapes on the end to help us, cannulate and get into those. And then this is a pigtail that we use to shoot a whole bunch of contrast into the ventricles. You can take a look at those. You can fill the end's rubber so that you don't dissect the arteries or the aorta.
So we'll get you guys the opportunity to come up and actually expanding balloons. This kind of just shows you a cross-sectional view. When we get that balloon into place across that blockage, we blow up that balloon, and what it's doing is pushing the plaque against the artery walls. So it's not and it's not perfect. In the past, they used to only balloon. They didn't have stents. All that would happen is eventually that plaque could just recoil right now.
Basically, it was 30 to 40% of everybody that just got a balloon would have it just re-stenosed. And so you think if somebody has 3 blockages you fix, you pretty much got a 100% chance you were coming back. That's the way it was.
It wasn't uncommon when I first started. We ballooned, take them back to the room, and before we even got them hooked up, we had to bring them right back. I mean, we've come a long ways. So with the balloons, there's different diameters. It's often used to pre-dilate to make it easier for us to put stents in so that we can keep that artery open. Nice thing is it's low cost. But I say like plain old balloon angioplasty is not used as the only primary method because it's not as effective. We also have cutting balloons. Little balloons that have kind of like razor blades on them that actually score the plaque. Sometimes we have patients that have really hard calcified lesions. So not often, but sometimes we use the cutting balloons as well. Stents, nice little cross-sectional view, and we've actually got some stents deployed here. We'll send those around so that you
These
can
are
see.
some of the bigger ones we have. They're kind of beat up from being in there,
But the stents are mounted onto a balloon catheter. Balloon's blown up, expands that stent. Stent's going to stay in there forever. It's never coming out. We have a lot of patients who say, will I ever get that taken out? Because you think medical procedures to get something put in and get it taken out. These become incorporated with the body. Over time, you have kind of a scar tissue that heals over that metal and it becomes incorporated as part of the artery.
And just to tell you how far we've come, when I first started in the Cath lab, we didn't have balloons, or didn't have stents. Stents first started when I just after I got in there, so they've only been 23 years or something like that. The initial stents that were approved for cardiac were biliary stents, so basically they're bile duct stents. We'd open them up, they weren't on a balloon, they were just in a little package, and we would take those and we would crimp them on a balloon with our fingers and roll them around on the table, try to get them on there, make sure that they stayed, and then we would run those up into the heart. Well, those old stents, biliary stents, well, if you look at a bile duct, it's not like this getting there. I mean, you're going, it's just a straight stent right into your, into your bile duct. Well, that stent wasn't very flexible, and the other thing is we couldn't see it on x-ray. So when you would put that thing up in there were multiple times where we would get it in and we couldn't get it around the bends that we wanted to get it where we needed. So in the end, the doctor would say, let's pull it out. We'd pull it out, and there was no stent on the end of it. Well, I don't know where it went because we can't see it under X-ray. So really, initially, there was multiple patients that we would lose stents in. I don't know where they were at. We hope they went to their leg or somewhere. I mean, we really didn't know. And there were times where we needed to get the stent shorter, and the doctor would actually use a little scalpel and we'd cut this like stainless steel stent, which didn't have probably very good edges on it either. And same thing, sometimes we'd get them in there and we couldn't get anything out, so we just have to inflate them where they are and go in. Now, these things can go all around bends. We can see them on x-ray.
They're already mounted onto the catheter, so we don't have to worry about that.
You're not doing this. And so, I mean, in 20 years, we've come a long ways.
And now we actually have drug coatings on the stents. We still have the bare metal stents that don't have anything other than the metal, stainless steel, chromium, cobalt. But they're the new stents. We have drug coating on there that helps prevent aggressive scar tissue formation, things like that. So.
One thing I kind of wish
come a long ways.
that I think might be helpful is working in emergency medicine with fire and EMS, or that I wish I knew when I did, is even the new ones that have a drug coating on them, patients have to take a medicine like an antiplatelet medicine for at least 6 months to a year after, to prevent the blood from just clotting into that stent, because your blood still wants to clot in there because it's a foreign object in the artery, and it will just clot off and cause a heart attack. And it happens fast. It only takes a day for that to happen. And so these medicines that when someone gets a stent, they have to be on these medications, and they have to take these meds every day on time. It's not something they can skip, because within a day or two, that'll clot off. So if ever you see a patient, like in their history, if someone tells you they've gotten a stent, and you know how people are with compliance with their medications and stuff, if you kind of find out that, well, yeah, maybe they've skipped it's called Plavix or Effient or Brilinta, one of those platelet medicines. If they haven't taken it for a day or two, you'll know kind of pretty fast. It's like, well, he's having a heart attack, yeah.
And initially, the same thing. We didn't have all these drugs. While we're doing all the procedures, we're giving them Angiomax and RioPro, all these different Agristat. Then they get the Plavix after. When initially, when we had those stents, none of those pharmacological agents were available. I mean, they weren't invented yet. And so every time we put in a stent, they would always clot. It was overtime for us every single time. I mean, they just never didn't. We had all sorts of crazy stuff we used to do with drip urokinase through the catheter, leave the catheter in their heart with a balloon in their heart and just dripping that stuff into their artery all night long. And they couldn't move. I mean, we did all sorts of crazy stuff. But really, pharmacological agents changed the whole game for us. I mean, this is the reason we can do all these other things. Because without it, they just clotted and we were back.
That's still one of the most frustrating things is kind of what Tim was saying, it's true, it kills a quarter of our population and there's really no funding to it, and the only way to change that is through education and stuff. And it's still so frustrating even with all the technology we have, as people come in with stents, you know, and, well, have you been taking your Plavix? Well, no, you know.
You've been taking your statins?
In Utah
No.
County, they're big on essential oils, you know. No.
I've been rubbing marigold oil on my forehead.
Sorry if any of you guys are like doTERRA reps, or like, we got some Diamond members here, they're like, oh.
But no, you laugh at it, that's a quarter of our patients.
So-
They will not take their heart medicine.
Yeah.
It's frustrating.
They're
So,
gonna kill you.
so as you guys already see, you guys have seen those stents that we moved around. They're just tiny, but the arteries are just that big. This is actually a picture of a new technology that they're coming out with. It's a bioreabsorbable stent. So they've come up with a polymer that actually will absorb over time and leave nothing. They're still working with it. It's not perfect.
It just got approved this year. We've been experimenting on Europeans for
Yeah,
the last 6 years.
good old
with
Europeans,
it.
they love to.
So we experiment on them before we bring it here. But it's not proving to be a ton better than anything. It's pretty
Yeah.
much just
Yeah,
the
they're-
same as everything else.
Yeah, they're finding that, in fact, our latest drug-eluting stents are actually a little bit better. So the hope is they can eventually figure out which agents will work
The only
with these
good thing
absorbable
is
stents.
if you need bypass in the future and you got full metal jackets, we put stents all the way up and down. You got nowhere to plug into. Whereas
Yeah.
these, if they absorb, you actually have a place to plug into, you know, 10, 20 years down the road when you're gonna need bypass.
So we're gonna kind of move on, go into acute MIs, things that you guys get to see. Get in there. We have patients who have heart disease, but their EKG can be normal. So we can have plaque that's inside the artery here. So it's limiting blood flow, but it's not gonna show any difference in their EKG.
In fact, in Vietnam, when they did studies on the soldiers, and your average age was what, 19 in Vietnam, 19 to 21. When they did cross sections of their vessels and stuff, it was something like 75% of all of them had some type of plaque buildup at that point. So most of us have it.
Most of us have it. It builds up over time. The ones that we treat really serious are the ones that have a clot. A clot that forms, completely blocking off blood flow to the artery, is when we'll get our ST elevation on the EKG. So we'll go in, we'll balloon it, start to see some resolve of that ST elevation, put in a stent so that plaque and that clot don't close that off again. We still have some ST elevation. It's going to resolve over time. Sometimes it immediately resolves and we get a nice looking EKG immediately, but there are times we'll send them back to the room and it's still resolving. So we've actually got a tool that if you guys want it, great. If you don't, no
There are
big
some
deal.
of these that it's an overlay you can put right on your EKG, and it can kind of show you exactly where that heart attack's coming from.
Yeah, so it's kind of a nice tool. Just overlay that on your 12 lead, and you can have a good idea which artery is being affected with that ST elevation. We love seeing the EKGs before the patient even shows up to our lab because it helps us actually prep the equipment that we anticipate we're going to need, and that way speeding up the time to actually treat the
If the doctor
patient.
sees that and it's in 2-3 in AVF, he's gonna go, okay, that's inferior. A lot of these guys initially will go in and shoot the left first, but if we wanna get that vessel open quick and our door to balloon time's up, they'll go straight to the right if they can see that it's in 2-3 in AVF. They'll go, okay, that right coronary artery's blocked, and they go straight to that one and stop the heart attacks. So,
Do you guys, sorry, do you guys get, one of you guys get our, when we transmit to the ER?
So we
we don't,
yeah,
but
they
it
go
does
directly.
come up to us,
Yeah.
so.
It just arrives with the patient, like in hand. And even
So-
that helps, because the first thing they do is hand us that in hand, and then.
And usually the
while we're
doctor
prepping, we
sees
can
it.
kinda
Yeah,
get
the doctor
We can
gets
forward
it.
it to the cardiologist.
Yeah, the
Yeah.
cardiologist gets it, so he'll even let us know, hey, looks like this is a right, or this is a, LAD, or.
So this is a case study almost a year ago. This, still currently, to my knowledge, is the fastest door to balloon time that I've been a part of. 17 minutes door to
Who
balloon.
was it, Gene? Who's the winner?
Yeah, who's the winner? I tell you.
Robert's Boyer special right
You guys decided
So-
to release that one.
The only way that we get a time this good is through you guys. So as you can see, this was from Provo EMS. We got initial EKG at 9. They got to the ER super fast and activated the cath lab. Fortunately, it was a weekday. We were already there. We were ready for them, and they got up to the cath lab. And within 7 minutes of it even coming up to the cath lab, we were able
This
to
was a
balloon it.
direct
It was-
to cath lab, so we skipped the.
So these are the kind of times that we're hoping for and anticipating with the new building, where you guys can just come right up to the elevator, right to our cath lab. So real big kudos to you guys. This is beyond impressive. So we had the initial EKG. A lot of artifact, looking kind of ugly here. See a lot of ST depression in the VU leads. You see some elevation into there. We take a look after we fixed it. Looks really good. Normal EKG, I'm not seeing ST elevations there. Here's what I want to show you guys. This is actually the video of it. It doesn't look completely blocked, but if you look right here where my pointer's at, it's hazy. You can see almost like a circle-like appearance.
See how slow it fills?
That's a clot. So that's a clot it's not completely closed, that artery off, but it's wrecking havoc. And we've got really slow flow going through there. When we get clot like that, and this guy particularly had a lot of clot, it was quite a challenging case. We were eventually able to get that section stented, and the wire's still in place here. We're getting blood flow to that heart muscle, doing a lot better. So now I've got another case study. This was somebody who at work had chest pain. Provo EMS went to check on him. The EKG in the field was actually initially normal. But thank goodness you guys treated him and not the EKG. Brought him into the ER, and his EKG started to evolve. Meaning he did start to get some ST elevations developing. So the STEMI was called. You can see here's after he was fixed. Looks completely different from that. So this is what he had. Had he been ignored and just thought, okay, EKG's fine, he's okay, and not brought in, that's the LAD, and that could have either made him a cardiac cripple, killing his heart muscle, or
Your
may not
LAD
have
is
survived.
your main pumping chamber, your left ventricle, so you get a hit there. Yeah, you take a
So
big hit
that's-
to your muscle.
So that's the artery after getting it ballooned open. All right, want to see? Yes.
I'm just curious, so, in the field, if everything looks normal, he looks sick, how quick can that turn into a STEMI? What's the,
Oh, it's
Different
Right
it's
then,
fast.
really, I mean, they'll
Yeah.
have people who come in, and same thing, just walk-ins, and they'll do an EKG, a few minutes later, they're still having chest pain, do it, boom, it's there. It can happen just like, as soon as the blockage is blocking enough of the blood going through, it'll happen.
It
And so
happened
as
this
the
morning,
clot
right before we
will
came.
just start evolving and getting bigger and bigger. And it's just,
Yeah.
it's seriously like it can be a minute. You can have one EKG that's fine, the next EKG can show STEMI.
so I think we had one that we saw a little bit of ST, and then once we got him kind of more on oxygen, laying down, maybe calmed down, but it looked better.
Yeah.
Yes.
And that-
When we got there, he still looked pretty sick, but at one time we saw it, and then the next time it was,
And it will,
better.
because that's an oxygen thing. So even if you've got decreased flow, you increase their oxygen, more hemoglobin is picking up, the heart muscles getting fed better, so yeah, it'll start to slow down. And also when you give the morphine and stuff, things.
Aspirin. We've seen
Aspirin,
some just
things
aspirin,
relax
just a
it.
simple thing of aspirin.
Yeah, aspirin itself can all of a sudden, boom, it just goes away. But if you don't fix it, eventually it starts building again. But yeah, it can happen just like that, you know.
Yep.
They don't
Can
always,
you-
they can resolve just as fast too, like when you go in and put a stent, you'll kind of just see that ST and just kind of, just take it.
Or in these outreach facilities, like if it's out at Delta, I mean, we don't transfer straight for PCI. We'll give them thrombolytics. So it like Gunnison and Sanpete, and it's like instant. You give them that thrombolytic, the TNK, and boom, the heart attack's over. I mean, we'll still bring them in and we'll fix them and stuff as soon as they get here, but yeah, I mean, it's instant.
Yeah.
So,
So you had a question?
Stand by thinking about it. Okay. So can you see it? Is it a direct proportional to the EKG versus what you would visually see on fluoroscopy? Or can you see it? Like you're saying the aspirin, it'll dissolve. Will you start to see it through video as well as the EKG? Are they direct
So
proportional?
yeah, so actually
Yes.
what will happen is they'll come in, we'll do the angiogram, and we'll see where that blockage was, and it was initially completely closed, but now it's opened up a little bit, and we get a little stream of flow. So it could be 99% closed, but at one point it was 100%. That medicine helped get just a little bit of blood flow
So
through there.
you can see it, and when you think of the clot stuff, it's not like all of a sudden a big clot goes there. You have plaque, and it has a cap on it, and 90% of, I mean, what we're trained in college, what heart disease was, it's not even the same science anymore.
Yeah.
So basically, it's a cap that ruptures. I mean, mind you, that cap you can have a little bit of plaque, it can only be a 30% lesion. And if that plaque ruptures, then all of a sudden you've got a heart attack. Or you can have a 90%. But there's always a plaque in there that you can always see where that culprit was.
So you'll see it on camera, but you won't necessarily see that plaque on an EKG. My question would
Yes,
be,
you wouldn't see it unless it.
unless
yeah,
you're
unless-
looking at it.
Yeah.
Because if you have an EKG that's bad and then interventions turn it to good, can you guys go in and see that? That's,
Yeah.
that's what I'm
Yeah.
So it'll still be there, that plaque and the rupture and all that. And that's why sometimes when we're not real sure, you know, they've had a little ST elevation or something like that. That's why sometimes we don't run them straight to the cath lab. We'll put them on a treadmill and exercise their heart to see if they start to have those. And so, unless it's a rupture, of course, you know, it's like this, and we're gonna fix them. But other times they're just having that chest pain now and again. We just stress their heart.
Yeah.
And
So
see
so
if
to
we
your
got it.
point, here was an EKG. You see in 2, 3 an AVF, and so that alerts us saying this is the RCA. This is the inferior area. So there was some blood flow coming through, but you
Yeah.
see right there, that's what's causing that ST elevation. So in the field, getting aspirin, getting some heparin in the ER helped facilitate to get some blood flow, but it needed to be stented open so that we had a normal looking artery. All right, what do you guys think about this EKG?
That's the elevations where? Yep.
Looks pretty ugly, right?
Where's that gonna be on the heart? You got inferior over here, 2, 3 AVF, you got septal there in the middle, what's on the right? Lady. Yeah, you're gonna have an anterior. And those are,
But I wanted to trick you because this is the actual patient's angiogram. They had normal arteries, what we call normal. Nothing blocked. Kind of baffled us because thought, no, that EKG was ugly, and the guy had all the symptoms. Turned out he had pericarditis, inflammation of his heart. Yeah, so you typically see it in all your leads. So look at, I mean, you've got just about all those leads. There's some discrepancies going on in there. So we can also get ST elevations on patients, typically female, that are having an active heart attack, come in and their arteries are normal, but then when we take a look at their ventricle, it's squeezing in a strange fashion where the bottom part, the apex of it, isn't squeezing, but above it is. We call it Takotsubo. Takotsubo is also called broken heart syndrome. It's named after a Japanese pot that they used to catch octopus. But they look like the real deal of an ST elevation MI, and even their troponin goes up. That it's oftentimes happens more often in females after a stressful event. Earlier in the year, we had somebody who's this isn't HIPAA because I'm not saying any names or anything, but they had a tragedy in their family. Somebody in their family passed away, and then within an hour, she was in our cath lab after having that tragedy in her life, and her arteries were normal, but everything looked like it was an ST elevation MI.
And there's no need for treatment?
So it's basically the docs say usually just give them some, ibuprofen, Toradol, just some pain, just simple pain medications because it's still painful, but it's going to resolve. It actually will resolve on its own, and then they just do a follow-up to make sure that the heart muscle is recovered because it's stunned. So if they have to, they'll give them beta blockers and echo follow-ups to make sure everything's okay.
But you're still proving that it's not.
Correct. So we already talked about our closure devices. This was the collagen plug that goes in, sits on top of the punctured artery, makes that seal. We can also use a suture that does kind of a purse string suture and closes up that hole. And then the radial, what we call a TR band, balloon inflates. Patients love it. We can see the puncture site. I just kind of go through, talked a lot. I want you guys to actually get up here, play around, open up the equipment, blow up some stents, ask any questions you have. Just come on up. Let's make it casual. So we do have complications in the lab, death, MI, dissection. There's a lot of things that can happen. But there is always more of a risk not doing the procedure than doing it. And when you come into the cath lab, where we try to reassure our patients, all of these things, you're in the right place for us to treat them. We can treat any of the complications that occur, and so patients are really scared, but they're in really good hands, and really well-trained individuals can take good care of them.
Initially, when we used to do heart caths and stuff, we've come a long ways, just to tell you that as well. I don't know if Lindsay was working in there when we used the MD76, the old contrast. What would happen every time we'd inject the right coronary artery? They go asystole. Okay, so that was just normal. So when you would do your pre-op teaching, you'd tell these people, hey, we may ask you to cough during the procedure. Please make sure it's a good, hard cough when we do that. And they'd be like, why? Well, it just helps the contrast get through your body and stuff.
No.
Really, he's done asystole. And so, but we don't tell them that. And you'd have people, you'd inject that. And the reason when you'd inject the right coronary artery, that feeds your SA node, So basically your pacemaker, your heart, and all of a sudden you just put molasses down in the artery that feeds the SA node, and the heart stops. And so you tell them to cough, they'd be like, no, cough hard. And that causes enough joules in their heart to actually restart their heart. But I always thought, man, if I was on the table and they told me to cough, I'd just wet myself probably. Because I know but they have no idea, and you just prep, just cough, and you want them to cough before they passed out. And so usually you'd get them to cough before they passed out.
Oh, that'd be awesome, yeah.
So, that was some of the stuff that we used to do. A lot of the things that we would put in their heart, you'd put these rotobladers, which we show you, it's a device that spins 150,000 RPMs, and it's a burr on the end. And so, if you guys have ever worked with tile, with the tile saw, you can put your hand on a tile saw, it's not going to cut you, right? But you can cut tile and you can cut brick and stuff. This is the same thing. It's a diamond tip burr that spins at like 150 to 200,000 RPM. It sounds like a dentist drill on steroids. This thing is cool. But you'd get it in there, and we can drill out like the hard plaque, so like calcium. And so it's just like a saw, you know, it won't hurt soft stuff, but it will, you know, chop up the hard stuff. The problem is if we got in a hurry and we put this in the right coronary artery as well, for some reason the heart doesn't like things spinning that fast in the heart, and it'd stop their heart as well. So we'd always, before we do this in the right coronary artery, we put a pacemaker in people. So temporary, just through their vein, we put it in, pace their heart, because the minute that starts up, something about that swirling motion, boom, your heart just stops. So a lot of things have changed. We used to, like I say, everybody used to clot. We did a lot of CPR in the lab. I mean, me and Lindsay, we had like 6 packs instead of kegs. And I mean, we did a lot of CPR, didn't we? It was a lot of people all the time doing CPR on them. Now it doesn't happen that much. I mean, when it does happen, things are really bad if we're doing that. So we've really come a long ways. We can fix people instead of just experiment on them and practice medicine. We actually do medicine in there.